It's towards the end of the day. We want to finish on a high. We're going to hopefully now have 4 very engaging cases that we've selected amongst the EBC group to showcase really the role of intracoronary imaging in bifurcation management. We've had a lot of attention this afternoon on DCB, but actually this is to look beyond that and to think about the role of imaging, which everyone seems to have moved on from, because we've got guidelines for CCS, we have guidelines for ACS, it's a done deal, imaging's done. Well, I was at a meeting in India at the weekend, and A.B. Mehta, who is a godlike figure in India, I see, had the most beautiful anecdote or quote, which was, "The eyes cannot see what the mind doesn't know." And I would challenge us all that although we're all talking about imaging and we might be spending the money on the probes, we've still got a long way to go before we truly understand what we're seeing and react to what we're seeing. And the purpose of these 4 cases, I think, really is to identify where imaging plays a critical role in achieving both acute, but most importantly, long-term outcome for our patients. And for me, I really do feel passionately about the fact that it really doesn't matter if you're spending the money but paying little attention to the information. It's about engaging with the technology, and we have 4 fantastic presentations to showcase that. I hope that we can have a very interactive discussion, and it's a great pleasure to be joined with Nicolas Amabile, who needs no introduction, partly because he was on the podium for the last presentations. But then, in addition to that, I think we should have Masaaki, Okutsu, Stefan Harb, Professor Legutko, Marco Zimarino. Dejan is in the building but not on the podium, and Mohamed, Zahran, it's lovely to have you here. So I think, without further ado, it's a great pleasure to ask Sinjini Biswas. This is an incredibly international group of presenters, Australia to India, to Paris, and then finishing up in Belgrade. So we look forward to the 4 presentations. Sinjini.
Thank you very much to the EBC organisers for this very kind invitation to present this case, which I've called "If You Don't Look, You Won't See." So this is a 78-year-old lady with CCS class 3 angina. She's quite limited, exercise tolerance of only about 50 to 100 metres. She saw a cardiologist, had a stress echocardiogram, which was positive for posterolateral ischemia. So on a background of a history of type 2 diabetes and hypertension. And she also has a hepatocellular carcinoma, which is on treatment. Her hemoglobin sits around 100, and the gastroenterologists and oncologists tell us that she's got an over 3-year prognosis, and it's pretty good. And otherwise, she's independent. This is a shot of the right, which shows you there's not much flow-limiting disease there. It's a distal branch vessel disease. And these are the shots of the left. So this was done by a colleague of mine. And hopefully you can appreciate that there is a very critical ostial circumflex stenosis, and also a bit of nodular calcium in the LAD, and some LAD disease. And they went on to do some physiologic assessment of the LAD and diagonal, both of which were negative. And so they stopped at this point. It was discussed at our interventional meeting. And some of the considerations that we discussed is, well, I think we should probably do PCI to the circumflex, but really, how are we going to go about doing this? Are we going to go back to the left main, or are we going to nail it, as we heard earlier today? We've heard a lot about DCBs. Are we going to use a DCB? And if we're going to use a stent, well, then are we going to kiss into the LAD? I've got to say, some of my colleagues do, some of my colleagues don't. I'm a fan of it, but my senior colleagues definitely think I'm bonkers.
Yeah, maybe at this point, I think we have time for discussion, and just to make the session be interactive, we can ask the audience what will be their approach to this quite complex lesion. So, first,
I think the complexity here, the decision is a little bit unusual because you have a very long left main. So if you want to go with the 2 stents technique, you need like a 30-something millimeter stent so you can protrude to the circumflex and cover it. I think in this particular case, maybe drug-coated balloon would be a viable option. after intercorner imaging, and we can see what happens before and after that. I think so.
I would suggest not to spoiler the result, to us to, I agree with the Nicolas, to us not to influence the audience. So it would be very nice and interactive to have a little bit of light on and to have, yeah.
So who has been convinced by all the debates from the afternoon, and who will go for DCB in this circumflex? Who has been convinced by Tom in the Cordis Symposium? Raise your hand. DCB, well...
You've picked on me, and that doesn't seem entirely fair. So I would just like, there's a caveat to this, which is the most critical point that we haven't really discussed throughout all of these sessions, which is that every meeting we hear DCB, DCB, DCB. And as I said, it used to be pop, 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 pop. The reality is we can't look into a crystal ball and say that this is going to be a DCB case. So if your hand went up for DCB, it has to go up with the caveat that it's a DCB until you have to cross over to a stent. And if it's a stent, you need to have a plan about how you're going to stent. Because fundamentally, that is critical. If we just go about thinking this is DCB, we are going to just move into a whole new realm of car crash angioplasty.
I think, can I just comment here? We can't really make a decision at this point whether DCB or stent. You have to prepare the lesion first, wire both, dilate the circumflex, and then decide. Because it's very difficult to, obviously we can discuss at this point, but the decision will be guided by how the vessel reacts. You might dilate the ostium, your left main dissects. The decision is made for you. You have to stent and then do a kissing balloon in the other branch. So it will be guided. Obviously, there are several options here, but it could be done by DCB, or we don't know unless we have done imaging and treatment.
It's always important just to have many strategies in mind and to apply. And so let's see what you did.
And I'm sorry, also for the sake of discussion, are you all happy with the functional assessment of LAD and diagonal? Not going to an imaging assessment? Are you all happy? Who is not happy with the functional assessment? Yeah, okay. Some. Take a mic.
The ostium of the diagonal. So you just put in a imaging catheter, IVUS, OCT, whatever.
Absolutely.
And then, as Dr. Rathod said, prepare the whole thing depending on the IVUS, OCT, and then take a call.
Okay.
So let's go.
Thank you. All right, I'll just move on to... So I have to say, for me, the ostial circumflex, I don't think we have the data. Solution de Novo is obviously going to report soon, but we don't have data in large vessel. And so for me, this was a stent case, not a DCB case. So my proposed and sort of what strategy we did end up doing was, my plan was crossover stenting, left main to circumflex. And I actually had to use a microcatheter and a Sion black to actually wire the circumflex. And then, as has been said, aim to predilate and then use some imaging, because I didn't think that I'd get an imaging catheter across without that. So this was, we actually had to start predilating with a 1.0 balloon, and then seriously upsized from 1.0, 1.5, 2.0 before we could actually, I couldn't get a 2.0 balloon across in the first instance. And this is the IVUS, and might help if the lights were down actually to see the IVUS, but essentially circumflex back to left main. You can see there's some nodular calcium at the ostium, quite tight ostial circ there, and then the LAD wire comes in, it's back to your left main. There's some, as you said, distal left main disease, and then a reasonable mid-shaft and ostial shaft left main. There's quite a lot of imaging here, so it might help if the lights are down. So just drawing your attention to a couple of the pertinent images. So starting on the left main, There's a reasonable landing zone there. At the polygon confluence, you can see that there is that nodule of calcium at the ostrum of the circ, but the opening into the LAD looks actually reasonably good. Going through then to the proximal circ, the tightest lesion, again, nodular calcium, a very, very small minimal luminal area, and then a reasonable landing zone sort of in the proximal circumflex there. About 3.7 millimeters. So at this point, given how the nature of nodular calcium and how difficult it had been in terms of balloon crossability, I proceeded on to perform rotational atherectomy using a 1.75 millimeter burr, 3 runs at high speed and then 1 at low speed to try and get some better luminal gain. Went on to do predilatation with a 3.5 millimeter non-compliant balloon, checked in orthogonal views, which I haven't shown you just in inches of space, but looked okay, but not fully expanded, as I think you can appreciate even in this one view. And again, then went on to perform intravascular ultrasound. So again, going back circ to left main, you can hopefully see there's still that nodular calcium just about there. Some luminal gain, I would say, from before, but again, the LAD comes in, looks reasonably okay. Concentric calcium, the distal left main, but good lumen, and then again, the left main looks good there. So just pertinent shots, that's the proximal circumflex, that's the distal left main. I wasn't at this point happy with my luminal gain at the proximal circumflex. I didn't think this was ready for stenting, and I considered my options. Upsizing the rotor burr was not really going to be an option because I think I'd need a 2.0. If it was a 2.0, I need an 8 French guide. I'm radial. And so I elected to use intravascular lithotripsy. This was done before we had the C2 plus catheter, so we only had 80 pulses to play with. And so we delivered 80 pulses from the left main to the circumflex, as shown there. Again, used an NC balloon, 3.5 millimeters, orthogonal views, look a bit better. And this is the IVUS that's playing on your right. Again, in the interest of time, I might just show you the pertinent frames. So you can see at sort of the carina, the LAD opening looks still pretty good. You can see the LAD wire coming in. And then the proximal circumflex, the frame on the left is what was achieved after rotor, but before non-compliant balloon. The frame on the right is what we have now. Not perfect by any means, and I'd be interested to hear if anyone would have done anything differently at this point, but I was reasonably happy that I'd got good expansion. I think we had about 4.5-ish millimeters, and I thought at this point I was comfortable to proceed on to stenting. So at this point,
Wait, stop. No, not show us. May I praise you for all the attention that you had in order to avoid to place a double stenting. I praise you. Up to now, obviously.
Yeah. Yeah. And I think
I didn't want to see the next one.
I was conscious as well of this lady who's 78 with a borderline hemoglobin. So that did, I work near our regional cancer centre, so I see a lot of high bleeding risk patients. So that was part of it. But yes, I was making an effort.
But Sinjini, I mean, you show in that image, importantly, that there is a change in the morphology of the calcium. Many people wouldn't have taken that step. And I guess the challenge back to you, I love that you did, and I would have done too. But I guess the question is, what would you do in the position where it hasn't responded? You've thrown the kitchen sink, is how I'd put it, at what I guess you'd call is a gnarly lesion. Is that, you've done 1.75 mil burr, you've done IVL, you've dumped 80 pulses into it. Where do you go?
Yeah, it's a hard question. I don't know that a cutting balloon would necessarily have helped here, so that's the only other thing. The other option would have been to stop, switch femoral and go bigger burr, or orbital would be the other option if I had it. But I don't know that orbital would have really helped here, to be honest.
Okay, sorry? After rotor, Wolverine would have been first choice.
After the rotablator, Wolverine would have been my first choice. Yeah.
In this particular anatomy, we should always think about orbital atherectomy instead of just rotablation, because with this angulation there is very often the wire bias, even with larger bore. You can have now the full ablation, and if with orbital atherectomy, the advantage is that you can also ablate going from distal to proximal, and then maybe you will achieve the better ablation of this calcified nodule. However, the data shows us that there is no much difference at the final minimum lumen instant area after all three methods. So what you did was probably...
I agree with you, but if we're looking at the top left panel, we see that the wire is not so far from the calcium nodule, so the wire bias is quite limited here. So it should have worked. The rota should have worked. So I think it was a very good choice just to start with that, but there's still some, it's still some unpredictable in this kind of case. Yeah, just go on.
All right, that's right. So proceeded on to stenting of the left main to the circumflex using a Megatron stent pot, and then post-dilated the proximal circumflex with a 375 NC balloon. And this was the result at this point before I'd done any imaging, and I was, fairly happy till I went, hang on, what's happening to the left LAD ostium? And I went to then rewire the LAD, and it was incredibly challenging. And eventually wired with the Sion Black, couldn't even get a 2.0 semi-compliant balloon to go, and eventually used an anchor balloon and then a circumflex to be able to deliver an IVUS catheter to really work out what was going on. And so this is just the IVUS of the circumflex to the left main, so just to, convince you that the stent result looked pretty good there. I'll move swiftly along in the interest of time to this LAD to left main. And again, you can hopefully see that there's obviously a high burden of calcium there. Again, there's a nodular calcium, that's at the diagonal bifurcation as you're coming through again. Where are we? Yep, you can see that the LAD ostium, there's quite a lot of nodular calcium, and then here you're back into left main. So again, just showing you the sort of the pertinent frames. This is now the LAD ostium, which on IVUS has now got an MLF 4 millimeters square. There's the LAD diagonal bifurcation, which also has some nodular calcium, which I was now a little bit worried about. The circ MSA was decent, even though expansion was eccentric, but I wasn't happy with the LAD. And I have to say, at that point, it was 5:30 p.m., having started at about 2 o'clock. And given the patient's stability, I elected to stop and return in 5 days' time because the patient was fatigued, I was fatigued. We were into an on-call team, and it was all getting challenging. And so I brought the patient back 5 days later. So this is the OCT. I chose to use OCT on this occasion, and firstly did an OCT of the left main to circumflex stent, which I'll let play on the right. Again, the expansions I think are pretty good. You can see the measurements there. And just to show you again the pertinent finding of the MSA of 6 millimeters square on the circumflex stent. More interestingly was, of course, this. I used a 2.5 non-compliant balloon initially before I did the OCT, really because I was worried that I wouldn't be able to get anything down. And you can see, again, going from proximal to distal, there is a very sort of nodular calcium bit of dissection there at the LAD ostium. But not very concentric calcium. And then again, this nodule at the LAD diagonal bifurcation, very heavily calcified vessel right throughout the LAD. And I'll just draw your attention to, again, the pertinent frame. So the LAD ostium, there is a nodule there, but there is quite a bit of dissection just from my 2.5 millimeter NC balloon, MSA of 4 millimeters square. A nodule at the LAD diagonal bifurcation, which again I was desperate to avoid, and a proximal LAD landing zone with eccentric calcium. So I did here decide that I was just going to use an NC balloon and thought that would be sufficient. And at this point proceeded on to put my second stent in. So this was a 3.5 by 12 millimeter Synergy drug-eluting stent. Again, pot, kiss, another pot. This was the final angiographic result, which I'll just let play. And then we did an OCT of the LAD. So proximal to distal, left main looks good. And you'll see shortly the circumflex coming in there, reasonable expansion of the ostium of the LAD, and nicely landed just before we got into all of that nodular calcium with the bifurcation. So these are, again, pertinent shots. You can see good expansion of the distal edge, 8.7 millimeters squared, and good MSA at the ostium of the, or stent area at the ostium of the LAD. And then similarly for the circumflex, in an interest of time, I won't play this again, but I'll just show you this. So 15 millimeters squared in the left main, good. The polygon confluence I thought was reasonably good. 86% expansion with 6.2 millimeters squared MSA at the stent. At the proximal circumflex, where it was the most calcified lesion, and a good distal land. So for me, the learning points of this case, I think if I was to do it again, I would have done upfront imaging of both the limbs of the left main. I think I was very focused on the circumflex, and the LAD diagonal had been physiologically assessed, and they were negative, and so it would have helped me greatly to take that one extra step, which would have been very quick. I think in patients, complex, high bleeding risk, sometimes it is good to keep things simple, but again, not being too blinded by that and using a two-stent strategy where needed is just the way to go. I think being systematic in complex PCI and troubleshooting appropriately throughout the procedure is important. And then finally, I think recognizing the impact of human factors in complex PCI is really particularly important. I think stopping on that first day when the patient was stable, I think was a sensible idea, because it meant that the patient tolerated the procedure well. They were back for another one, even though they did tell their referring cardiologist that it took longer than bypass surgery. Thank you very much.
Excellent case, really nicely done. I would just like to put up some other point. I have Masaaki Okutsu sitting next to me, and I would like to ask you, if you would have seen the CT of the patient, could you have predicted what would happen?
Thank you very much. The CT can detect the calcification very easy. We can, the calcium volume and the calcium distribution is very easily evaluated by the CT. So there if such a calcified and bifurcation region is also a good candidate to the checking the CT. The usually calcified region is contraindication of the CT examination. However, recently, the calcification is evaluated by CT. So there, like a case, if we can know the very calcified bifurcation region, we can choose the atherectomy device at the first time. Then the more aggressive atherectomy. So this is one good option to evaluate the calcification.
Yeah, thank you, Sinji. Thank you very much for this lovely case and brilliant management. And for the sake of time, we're going to move to the next speaker. We're going to ask Preeti Sharma to come to the podium.
Good evening, everyone, and I want to thank EBC for the invitation. And I'm going to present this case. The title of my presentation is The Day When IVUS Bailed Me Out. So this is a story of a 50-year-old male who is a neurophysician, happens to be my college senior, and in risk factors, he was hypertensive. He presented in my OPD with a history of chest pain on minimal exertion for 2 weeks. I advised him to undergo a stress test. Treadmill was positive in second stage with a Duke score of -12. His ejection fraction was normal. So I asked him to undergo an angiogram, and this was the angiogram. So as you can see, the left main is good size, and the circ is having some plaque and some plaque at the ostia of OM branch. And as we move forward, we see some plaque at the ostia of LAD, and this is a clear-looking discrete lesion in the LAD, 90%. Though we can see that there is a involvement of a diagonal branch, but we see 3 sizable diagonals, so not to worry. We have 2 good diagonals after this diagonal branch. So on IVUS, I could see there is that there is some disease in the proximal LED, and I was trying to put my stent into the proximal LED, but with the accidental protrusion, my stent went up to the left main, which I could immediately recognize at that particular point of time. And for the sake of completing the procedure, I did a proximal pot with a 4-5 balloon in the left main. And this was the end result, as you see in the right panel. Nice looking LED, LCX, and the good left main. And I was really happy that the complication which I made there, I could tackle it in the time. And I was happy. But to my... So your fears, they come true. And this, my senior, he again came to my OPD after 6 months. And this time he again has the chest pain on the similar kind of pain on exertion. And I again advised him to undergo a stress test, again positive. Then with a heavy heart, I thought maybe I should see where's the problem now. So this is the RCA, some plaque in the mid-RCA. And this is the first shoot I take. The LED LM is looking good, but there is progression of disease at the LCX ostia, as we can make out. And in the next shoot, you can see that the involvement of a large OM branch there. So LCX OM bifurcation lesion, and we see that the LED stent is flowing well and all the diagonals are flowing well. So if you want to take a pause here to decide that what we want to see at this particular point of time, obviously this patient is for angioplasty, and how we're going to do it, we might differ in our plans, but my plan was that I wanted to, so I knew that I had dilated this stent with a 4-5 balloon, and then if I take my wire through the LED stent strut, because there are 2 or 3 struts which are into the left main, then wire into the LCX, but before doing a balloon dilatation, I have to check with the IVUS whether I have, actually there is no abluminal entry into the LCX. And then lesion preparation based on the IVUS findings, and then I was open for a stent or DCB, though I didn't discuss with my senior that what are my plans. Yes, I did tell him that he needs an angioplasty. And the stent strategy, if I had to do a stent strategy in this patient, so it is a stent which is 6 months old. So internal crush in this patient is not an option. The only option I could think at that particular point of time, looking at the narrow angle, both branch being on the same size, the culotte strategy came into my mind that it is a preferred strategy in this patient. So this was the idea. With this idea, I proceeded. This was the wire. Once I wired this, I checked. So this is pullback from the L6 after the initial wiring. As you can see, this is the OM branch merging there. And as we move forward, we see that there's a disease progression. This is a fibrolipidic plaque into the proximal LCX. And now the good point is that we are through the stent struts. It is not an abluminal wiring. And the stent in the left main is actually, it is 4 to 5 millimeter to my surprise, and it is well opposed in that particular area. So with this, we dilated this after, so this is the IVUS summary. This is, my left main is 5.2. The stent is around 4, which I dilated with 4.5, it is 4. And then the distal LCX or OM branch where I'm trying to put my stent, the distal size is 3.2. And as we can see, there is a fibrolipidic plaque at the ostia of LCX. So a 3O NC balloon dilatation, and post NC balloon dilatation, this was the result. So the middle panel, we can see that this was the post NC balloon dilatation. I discussed, I was open for a DCB. But at that particular point of time, he was not willing for a DCB, and then with patient decision, we went ahead with the stent strategy. We took a 3.533. I knew that my distal circ is 3.2, so I deliberately took a 3.5, so because I knew that the left main is 5, and then deployed it at a 7 to 8 atmosphere, and then pulling my balloon, I deployed it at a 12 atmosphere. Pot with a 5.6 balloon. And then LED was rewired through the stent struts. And through the LED, we dilated the stent struts with a 312 balloon. I was happy that I did a kissing balloon in this view. As if you see RAO caudal view, it actually looked good. I thought I have given a very good result, and let's do IVUS and let's do another shot. But to my surprise, when I took a LAO caudal view, as you can see, there is some haziness as the LED ostia. And after 1.5 hours of case, when I saw that, there are 2 or 3 things which came to my mind, but I thought, let's check it with the IVUS. So on the right panel, you see that this is the IVUS pullback from the LED after doing the kissing balloon dilatation. As we move towards the LED, you can see that the stent struts are towards the LED. This is a carina shift, as is seen in the bold blue arrows. You can see that there is some deformation of the stent or carina towards the LED, as we can make out with the IVUS. So now, looking at this, I just wanted to check. So as we know, these are the pitfalls of leaky culotte. Too proximal or too distal rewiring can cause some stent gap into the vessel or can cause a new metallic carina, single layer. But in my case, I had some clue that it is probably the inappropriate kiss which has actually led to this problem. And I again wanted to check the wire entry, so it was to the middle cell, not too proximal, not distal on the stent boost. I again did a pot, and then a sequential kiss, this time very carefully, 3512 at 16 atmosphere in LED, then in circ, simultaneous inflation, kept it for 20 seconds, and then deflation. I used a single cock method, which I could actually learn from the EBC cases earlier. And this time after this, so this is after this we had a simultaneous deflation. And I was pulled back from LED as now I could see that now this proper kissing has given us good results. And this is a proximal LED. As we move forward, there is a small new carina you see, and then there is no distortion. As you don't see any distortion, this is a good polygonal confluence. And I could achieve an area of around 20 millimeter in left main, 9 millimeter, this is a polygon of confluence, 9 millimeters square into the LED. So good result. And, but to my surprise, the initial 2 or 3 stent struts, as you can see in the lower left panel, you see the stent is not dilated. Maybe I did not do a proper pot. Even after doing 2 or 3 pots, the proximal end of the stent was not proximally opposed into the left main. So again, this is IVUS from LCX. I could see that the stent is well deployed, and in this circ, we achieved an area of 9. This is a polygon of confluence. And then after checking out that the proximal stent struts are not well opposed, I went again, did a repot, check my balloon position, proximal balloon position on the stent boost, and this was the end result. So this patient, he is in my follow for past 18 months and is really doing well. There is no recurrence of angina. So my take-home message from this case is that successful outcome in 2-stent strategy actually relies on proper execution of all procedural steps, including final kissing balloon dilatation. And intracoronary imaging, as we all know, has a class 1 recommendation in complex lesions. And in these kind of lesions, in bifurcations, it helps us in knowing the morphology of the lesion, stent size, pot balloon size. And while you're optimizing your result, it actually helps you in diagnosing any complications, as in my case, the timely recognition of LS, longitudinal strut deviation, carina push towards LED, and proximal malapposition of left main stent. Thank you.
Thank you very much for this very nice case. Do we have any question from the panel? Dejan.
It's more a comment, I think. I think this is a beautiful demonstration of how intracoronary imaging translates the knowledge from bench testing into clinical practice. So the simultaneous deflation of kissing balloons is something which I think we don't really think about, that it can make a problem. And here it did make a big problem, actually. And without the final imaging run, we would not have known that. So I think this was a beautiful demonstration of how intracoronary imaging is important in that respect.
Hi, that was a great case, thank you. Can you comment on what you think the mechanism of that osteal lesion was? I mean, there was no atheroma there originally. Do you think it was aggressive atherosclerosis, or do you think there was a mechanical issue with your initial stent? I can't remember whether you did a kiss or not at your initial stent, because that was just came back, so I'm assuming you didn't.
So, very nice question. Actually, I was also wondering about this, but I could not see any stent struts deviating onto the ostia of the LCX. So in my opinion, it was aggressive atherosclerosis, which we commonly see after doing LM to LED crossover if we have not achieved a good result or not have done final kissing balloon dilatation, opening the stent struts towards LCX. You do see these kind of progression of disease into the LCX ostia in our experience. Yeah.
So
Preeti, you've demonstrated a beautiful systematic approach to multiple runs of IVUS. Peter alluded in the last session to the October protocol and the fact that we know from that we will detect these kinds of changes. Is it practical? Do you do this for every case?
If I'm doing left main case, yes. I take all the pains because, you know, we want to avoid restenosis. And if we are challenging CABG and we are saying that we are doing equally good PTCA, we have to put all the efforts to give good results. Okay. So in LM, if I'm doing a LM bifurcation, then I use imaging and maybe 2 or 3 times. That is why I use IVUS more in my practice. And OCT, yes, if I'm using OCT, I'll take 3 OCT runs if I'm doing a left main case. Okay.
Thank you very much for the group presentation. The great performance of the complex stenting implantation. IVUS with the IVUS guidance, and however, in IVUS image of the target region, this is a very soft plaque and acute progression region, and it might be the good candidate DCB. Of the DCB. Yes. And if, yes. Of course, beautiful procedure. However, if possible, avoiding the complex stenting is might be better. So, what do you think about this thing?
Yeah, DCB, to my mind, also, would have preferred DCB, but patient was a doctor. He's a neurophysician. He was not willing for. I had to take consent from him. He was not willing for a DCB at that particular point of time because I could not show him good data regarding a DCB in the large vessels. That's what the only point towards decision making in a dual stent strategy in this patient.
One last question, but just also the QR code for voting. Just remember, we have had 2 cases, 2 more remain, so have it ready in your phones because we're going to be short of time.
So do you think opening the struts after the first index procedure would have made a difference?
So mostly, whenever we are doing LM to LED crossovers, in my opinion, my practice, I have seen if you are not opening struts towards the LCX, maybe 10% of the time, these patients, they do come back with the ostial LCX ISR. So non-left main and left main bifurcation, they are different. If we are doing a left main crossover, in my opinion, we should try and open kissing balloon, try and open struts towards the LCX.
If you don't open the struts, you completely change the flow dynamics. And that is a cause for restenosis, or maybe a de novo lesion. Yeah.
Preeti, thank you. That was a wonderful presentation. So we move on to the third of the 4 presentations from Andrei Florescu, Beyond the Struts, Solving Guidewire Ambiguity with Intravascular Ultrasound. Andrei.
Thank you. Thank you very much. Good evening, ladies and gentlemen. My name is Andrei Florescu. And I'm an interventional cardiology fellow at Institut Cardiologique Paris-Sud in Massy, France. And I'm honored to present to you this clinical case presentation, which is called Beyond the Struts, about how to solve guidewire ambiguity using IVUS. Okay. So the case, it's about a 65-year-old female patient who was hypertensive, and dyslipidemic, and who came to us for stable angina, CCS class 2, despite optimal medical therapy. So this is her coronary angiogram. So you can see there are basically 2 lesions. There's a severe stenosis of the proximal LAD and an intermediate stenosis of the proximal left circumflex, with no visible stenosis at the left main level. Here you can better see the 2 stenosis on the freezed images. I don't know if, you obviously can see them. So this one and then the left circumflex. So yeah, because there's no significant lesion at the left main level, what we decided to do was to do a stenting of the proximal LAD. So we went in with an EBU 3.75 in the 6th French, and we advanced the Chion blue down the LAD, and we tried to nail the LAD ostium with a 3.5 by 15 millimeters drug-eluting stent, which we inflated at 12 atmospheres for 30 seconds. Unfortunately, what sometimes happened to us also. So yeah, some of the struts ended up into the left main. So what we did is that we advanced the second guide wire, BMW guide wire, into the left circumflex, and then we paused and asked ourselves what's going to be the next step. Because actually an important question arose at this moment: where's this guide wire going through? Because either it was going into the stent at the beginning and then going out through the struts into the left circumflex, or it could have been going between the wall of the left main and the stent. And the strategy would not have been the same in the two situations. Because in the first situation, if the two guide wires are into the stent at the beginning and then the second one goes into the left circumflex, we can go with the bailout kissing balloon, with a culotte, bailout culotte stenting, whilst if the second guide wire is between the wall of the left main and the stent, then a DK crush technique would be more appropriate.
Beautiful presentation. I think you may not have caught the agitation that was occurring in the front row from the godfather of Massey. But talking about conditional stenting, I have a feeling that we might be heading towards conditional imaging. That's a new French term for the use of adopting intracoronary imaging midway through a procedure.
Can we check
some comments, Marco?
Can we check the angio again?
Oh, yeah.
Can we check the angio
I don't
at
know
this
if
point?
I can go back. Can I go?
Yep, you can.
No, after the stent deployment. No, after the stent deployment.
Yeah, okay, just... Oh, okay.
No, after the stent deployment. Because
after the stent deployment.
At the point we are now. At the point we are now. After stent deployment.
Here.
No, but the angio. Anyway, if you ask us to leave it this way, I would like, what is this way?
I mean, just do nothing more. Just
of course, we're going to remove the balloon. But
no, but that was not the question. It's just, yeah, okay.
But that's your defense.
Because it's not a bad option to leave it that way. So if there is an unsatisfactory result, I cannot leave. But if the result is nice, why not?
So I think that's a good point, just to make a poll in the room about different options, about who would be okay to leave it like this, without the balloon, of course, and we would go for potential bailout culotte. So if
it seems that you think that you re-enter through the cell, but you can be outside.
Yes, of course, that's the point. We don't know where the wire is. At this
maybe you are not through the first cell of the stent. You are on the wall, but outside the stent.
Yes, I completely agree. That's a possibility, yes.
Yeah.
So,
there is a way to discover without imaging. You remove the wire from the circ. You remain with the wire in the LED. You go with the balloon in the LED size to the LED size. You inflate the balloon exactly with the tail of the balloon in the left main. You occlude the stent, and then you go with the wire. We will not enter in the stent. We will go in the circ.
Yes, and also there's two things. The first thing, what Marco said, I agree with him, because if you take out the balloon, we know from the previous lectures along the day that putting two wires to mark the
why circ was not wired
is one of the options that are actually described to make the procedure properly. This is number one. So it might not be as bad as you are predicting that it's going to be bad. And the second thing, as Remo said also, the balloon in the stent of the LED, 1-to-1 size and inflated, will force the wire to pass in the right track or in the right direction, yes.
So in the first place, why the circ was not wired when you are stenting? Why the circ was not protected? Because there's a circumferential lesion. This is almost like a Medina 111. we don't know the left main, distal left main, whether there's a plaque.
Well,
Mariano.
What is not clear?
Okay, so just to answer to the question about the...
Wait, Mariano.
What is not clear how you made the wiring of the circumflex. So you show us this imaging, but we don't know how you did the wiring of the circumflex. So did you pass directly nearby the struts, or did you put the wire that is now on the circumflex first in the LED, coming back, pulling the wire, and trying to wire the struts, the most proximal struts? This is something that you can consider, because at that point, if you are wiring the most proximal struts, you can pass a balloon like 1.5 or 2, and then you can make a stand boost, stand vis to understand a bit.
Well, this was a stand enhancement technique. This is a stand boost. I don't know if you, by seeing this, you can know for sure where the wire is.
So this is fantastic. We have interaction. We've got Remo, Gabor, then we're going to move on to see where we head
I
next.
want to just a teaching point. If you want to go through the strut of the stand because you believe that it's protruding too much, okay, by angel, is protruding too much in the left main, and you want to go through the strut of the stand in the circ, the best option is a dual lumen catheter, because you have the wire in the LED, take a lumen catheter, you orient, and then you are inside the stand, and then you put your wire. If you want, because the protrusion is too small, for example, the circ is a dominant circ, and is a small LED. The stand in the LED was a 3.0. It will not expand because it's not a 3.5. You know exactly this situation. 3.0 stand implant in the ostial LED. A big circ, then you have to convert in the decay crash. Then you have to take the balloon, occlude the LED, go below, crash, and convert in a decay crash. This is the strategy. Then, if you don't know what you are, you take the IVUS and see where you are.
Yeah, but with the IVUS...
Gabor, quickly.
Yeah, so very quickly, I think trying to find out what happened and where you wired, it's already a late reaction. So first, probably you should have an idea. Do I want to wire through a strut because I want to make it culotte, or do I want to wire behind the stand because I want to do decay crash?
Yeah.
And probably first an imaging from the LED backwards to understand how much this protrusion is, because you already missed the carina or the ostium. Why do we believe now that the vessel is there where you drove it? We have no clue. So first, I think it's important to understand what happened, and then with a strategy, wire the circumflex if needed at all.
And the other critical element here is knowing the stent platform, and I can't remember whether you told us what this stent was, but if it's a closed cell, 4-linker, 4 connectors in the proximal, this may be a real challenge in terms of how it will overexpand. Himanshu showed a very beautiful case earlier.
I think it was a Biofreedom stent.
Okay. Andrei, sorry to disrupt you so much, but show us what happened.
Okay, no, just to answer. So we didn't place the second guide wire at the beginning because we judged that the left main was devoid of any significant lesion. Then the way we thought about it is that at this point, we're definitely going to do something about it. And if we were to do something about it, the guidelines say if you stent the left main, you basically have to take out imaging. You have to use intracoronary imaging. It's what we did. So we use this tool, that is IVUS guided imaging, to see the precise position of the second guide wire. And here you can see the run from the LED to the left main. I'm going to leave it for a bit so for you to analyze it, and then we're going to stop at some key frames. So here you can see the stent. Obviously, as expected, the severe malapposition, it was one of the reasons for which we decided to do something, but that we could have expected from the angiogram aspect. If we go back at the very beginning of the stent, You can see we draw the stent with red dots and then the lumen of the vessel with yellow dots. And you can see the two arrows that are showing the two guide wires. And you can see at the beginning, at the stent, the two guide wires are going inside of it. And the one depicted, shown by the blue arrow, is then going down to the left circumflex. So we had our answer. So the best strategy from our point of view at this stage was to do a bailout culotte stenting. We also analyzed the dimensions of the left main in order to choose the best size for a balloon in our stents. So we continued our procedure with the kissing balloon inflation with non-compliant balloons.
I would have left that way. Once the damage is done, I would have left that way.
So can you show us the result at the end? This is the result?
No.
So we discuss about this.
Okay. So this is the, I don't know where. So this is the kissing balloon inflation. This is the result of the kissing balloon inflation. This is the stent that we position from the left main to the circumflex across the LAD. And we did a pot with a 4.5 millimeters balloon based on the information we had by IVUS. And we did a final kissing balloon inflation with this angiogram.
Sorry again, but the stent is not till the ostium of the left main. The ostium is not covered.
There is a nosology remark. This is not a culotte. Some people are calling that a string, but certainly not a culotte, because they have to overlap at least proximally in the proximal main vessel. So it has been described. I don't know who named this a string. So
I think Gabor did the string technique a couple of years ago at EBC. But But you saw the restriction, until you did the kiss there on the stent boost. There was that clear restriction caused by the cell expansion, the capacity of the device. Yeah. So it'd be interesting to look at the IVUS to see exactly whether there is some persisting restriction that's not so apparent by angiography. But I guess that would be one of the concerns. Marco, I'm not sure I feel as strongly about covering to the proximal left main. I'm not sure that is a necessity. I don't know what others think.
If you have the guidance of the intracoronary imaging and you can analyze that the proximal landing zone in the left main is free from disease, I'm not sure that it makes sense just to cover the whole ostium. Otherwise, you can expose to some complications.
Do a second projection.
But it's a debate between interventional.
Yeah. So I will just tell you something to sleep well. You know, I did that at the beginning with Thierry Lefebvre. We did that many times before understanding what occurred at 6 months. We were difficult to reach the circumflex. So we knew this phenomenon since a long time. We did the same mistake, but I think that normally you are supposed to have information in Massey to avoid that. So I'm sure.
Tom, I think you were commenting before. We know that DCB is very in, but it's still a EBC. We are not talking about port enough. This, if there is a malapose stent in the distal left main and you intend to wire the side branch and you want to convert it into a culotte, do you think first doing a port size to the left main followed by rewiring would make the procedure more predictable? It's EBC. Come on, we should talk about port at all steps now.
In the city of port, yeah. I mean, you have a point that I think that this was such a short protrusion. I guess the only concern would be whether the pot balloon would actually make impact. You'd have to be protruding into the distal main vessel with then the concerns that you might be oversizing and injuring that. So I think there are trade-offs. I mean, you've shown very elegantly that you were able to wire it and confirm it by the imaging. So I'd probably err on the side of this technique rather than pot. Yeah.
I just wonder, did you consider doing DK crush? I don't think I would have done a culotte or a string in this.
Well, we would have done decay crush if the second guider would have been between the wall of the left main and the stent. But at this point, we did the bailout culotte stenting, which we considered more appropriate, which is kind of like a string culotte, but more struts, not only a single one. It was the decision we made at that moment.
This case shows us that if we do the very proximal LAD stenting, it's always good to have a wire in the side branch. And then it's much more easy because you are protected. If you have this jump, then you have the wire and you don't need to check how to rewire. This is the first, I believe, important because it's cheap. Wires are not very expensive.
Andrei,
second, if you only partially cover the circumflex, not going to the distal left main, but proximally to the bifurcation, I still believe that decay crush would be the better option than just going for something which is even not culotte, as you said.
Can I have just also one remark? Dr. Louvar and also the others are also right that this is not culotte basically, because you only have just one piece of the strut going through, and this is not culotte because you would have to have overlapping studs. So probably decay crush, and Jacek is also right, that maybe for later purposes, and Michael is also right, that for later, I think decay crush would have been a much better option, because now you might have a good result, but you are restricted by the capacity of the biofreedom stent to at least go all the way to the other side. And you saw, and I'm very interested how the IVUS is going to look like, because I'm not sure, because that the stent did not open up quite well. So I would be very interested to see the last IVUS images, because I'm not sure that this is going to be, for the long term, it's a good result for this particular.
So Andrei, we have to thank you because you brought us back to our EBC happy place. We now can talk for the rest of the evening. I think dinner is now reserved at midnight. If we just want to talk about whether culotte's a culotte or a decay crush is nano, mini, or whatever it might be, show us the IVUS again if you could, and I think we're going to have to close out with how you've finished this case, but it's fantastic to have provocative discussion. Well, actually, you show a beautiful result there, right? Albeit there's a lot of metal that maybe would have been avoided by not nailing the ostium in the first place. Please close out with your conclusions.
I'm not aware of any studies that are showing decay crush, especially in such a situation, would be better than culotte. And to be frank, in our center, we basically never do it. So I think it's better to do the technique which you are most familiar, especially in complicated cases in which things don't go the way planned. So that was one of the main reasons we didn't do decay crush. And honestly, we rarely, extremely rarely, if never, we don't really do it, okay?
I want to...
Please let him conclude and then you can have a comment.
No, so this is not a message, because if you put a 3.0 stent in the LED, you cannot expand at a 6 millimeter 3.0 stent. So you have this string effect with this restriction. So you nail the patient again with the culotte. You should know what stent was implanted and a maximum expansion of the stent in the LED. And then you decide to do a culotte or a decay crush. It's not a theory, it's a practice.
You don't know how the metal is going to be disposed at the LED ostium. So decay crush should have been the procedure as a planned procedure, not now. This is not called decay crush now. Because you don't know how the stent metal is going to be disposed at the ostium. You're going to have a tough time negotiating a crush.
No, it's not decay crush, that's right.
I'm saying, any suggestion of decay crush here is going to be very tricky and difficult.
So this is the result. You can see MSA, which is quite good. We had 8.3 basically in the stent towards the LAD and 6.36 square millimeters in the circumflex. And at the left main, we had 13 square millimeters. So the take-home messages of this case would be that ostial stenting is technically challenging, and nailing the ostium can be quite hard, and the stent struts can end up in places you don't want them to end up. That wire position relative to the stent struts can be hard to assess. And in order to know precisely where guide wires are in complicated situations, you need tools. And one of the tools is intracoronary imaging. In this case, it was IVUS, but it can be obviously OCT. And the choice of the strategy, the size of the balloons and the stents are best based on intracoronary imaging, which offers also good procedural precision. Thank you.
Andrei, thank you for, we haven't got time for another question, I'm afraid. Thank you for a very provocative case, which has created lots of debate. In your defense, the stent that was in the LAD, obviously there was only one crown protruding into the left main, and the expansion of the device from circumflex to left main was appropriate, which is why you achieved such fantastic minimal stent areas in the circumflex. The only area of constraint, as we've discussed, is where that first crown is being massively overexpanded to oppose onto the opposite wall of the circumflex ostium. But you've achieved there, as you showed, a circumflex MSA of 6.5. So it creates fantastic debate. There's lots of opinion. My lesson that would come from this is not to nail the ostium, which I think is probably your conclusion too. So we move on to the last case, which is... last but not least, certainly, Zlatko, it's a pleasure to invite you up to show, again, a beautiful case of visualization, both by intracoronary imaging and then I think technology that goes beyond.
Good evening, everyone. It's a really pleasure to be here, and thank you for staying this late. I will start from the middle of the case, because this is the situation that I face this problem. Young colleague made a coronary angio, and he called me and said, we got an in-stent restenosis, we get stent in circ, which has restenosis, and we have stents in LAD and diagonal with restenotic lesion. And what should we do? We try to wire, place a wire, that's the start of every procedure, but as you can see, we can see the contour of that stent in the circ, and we can see the wire every time going behind it and into the diagonal. So it's clearly outside the path of the strength of the contour. We don't have the stent boosted in SCAD lab, so we could not see it more properly. So now let's go back to the beginning of the case. This is a case of 35 years old male patient, so very, very young patient, which referred to our hospital for an unstable angina. He has classical risk factors except diabetes, 65 ejection fraction, no wall motion abnormalities, and ECG without changes. And in that first procedure, we can see that it was a two-vessel disease. The circ was occluded, and there was a diffuse disease on the LAD and diagonal. And the operator in the first procedure decided to do PCI with implanting 2 DES in circ in overlap fashion. And you can see this is really big circ. It's probably codominant circ. RCA is not big. And for the LAD, they decided to do stepwise provisional. They had 2 wires. First, they did predilatation on the diagonal branch with 2.2520, and this is the result after that. So they now proceeded with provisional stenting. After implanting 1 long DES at 16 atmospheres and performing POT, they had the section proximally, so they added another stent, and then they came back to the diagonal and performed kissing balloon with 2 all balloon in the diagonal and 3 all to LAD. So this was a really gentle kiss just to open the struts, I believe. But after the kiss, they had slow flow, sluggish flow, so they had to do something with this diagonal. And they decided to do tap stenting, and after placing 2 drug-eluting stents in this diagonal in overlap fashion, because they had a long dissection, this is the moment, exact moment where they positioned the stent in the diagonal, final kissing, and angiographically it was fine result. The patient was discharged with no events, and everything was fine for 7 months approximately. And then he got recurrence of symptoms and came back to our hospital for immediately recoronography without prior stress testing, and we are now at the beginning where I face this situation. So we have restenosis in almost every stent. He has 2 stents in circ and 4 stents in LAD diagonal, so lots of stenting done. We dealt with the circ really in straightforward fashion, dilating with DEB 3.0 and NC balloon, and this is the final result. But when we faced the diagonal and LAD problem, we had the situation of wire going outside. So the best strategy to proceed in this situation was to perform the imaging, of course. This is the pullback from the LAD. I think we will have time to watch it in full length. We can see that there's a restenosis in distal part of the LAD stent, which is not that concerning. Now we are coming back to the diagonal branch. There is a more restenosis in this segment, and here is the stent in diagonal, and now we are in proximal LAD. You can see very unhomogeneous proliferative restenosis in the proximal part. And the length of that neocarina that they created in prior procedure was measured to around 3 millimeters. So this was my angiographic understanding of the problem. This was the pattern of restenosis. It was really abundant in the proximal segment of LAD. And when we come to the opening of the side branch stent, we can see that it overgrows it completely. The stent can be seen emerged in this restenosis. And you can see just above the neocarina, there is small opening where the wire went. Luckily enough, there was a space for wire to pass through, and you can see that the stent is really overgrown with the restenosis. And this was my understanding of the problem. The stent is in diagonal is in blue. It was 3 millimeters pullback in the LAD, and the restenosis basically covered the stent. So that was really the issue, why we couldn't go through the stent. So now the situation, how to treat it, is really pretty much straightforward.
Sorry. Perhaps Goran won't invite me next time. But at any time, was this patient thoroughly discussed with the surgeon? 35 years old, with double coronary artery disease. The second time with extensive restenosis on LAD and diagonal. In European Society of Cardiology, we are discussing very attentively the heart team discussion in cases like this. This is, I'm sorry, we are not here to show how good we are when can discuss. This is a 35 years old male.
But I have to ask, is he too young maybe? Too young for bypass?
Yeah, but it has diffuse disease. Also the circumflex.
But there are other methods, it's not only stents around. So
after the first time, there are reasons to discuss with the surgeon, The second time, perhaps there are more reasons to discuss with the surgeon. Lima to LAD with an ipsilon jumping on the diagonal is not blasphemy, in my opinion.
And the circumflex has 3 mammary grafts. You have 3 mammary grafts? No.
Second time also.
No.
Marco, I think
35 years old.
I'm sorry to interrupt. Huh?
I want to
won't invite me next time.
I don't want to send to surgeon. He's too young.
Okay, but patient is definitely stent non-responder, and if you go to really very skilled surgery guy, he can do complete arterial revascularization.
Yeah. So this is valuable discussion again. Sorry, Vani, you had a comment, and then we'll come back to that.
Just a really quick one. I think you have to look at coronary artery disease as a lifetime journey. And at the point of diagnosis, if you're 55, then you're potentially living with it for 30 years. But at 35 years old, you're looking at someone who's now got 50 years potentially to live with coronary disease, and it's how you're going to buy time for that person. So if you send a 35-year-old for bypass surgery, whilst I completely agree with your points, he's come in with stent failure, but the stents in the first procedure were way too small for him. And that's why imaging is important. But if you send him for bypass now, we know that 50% of vein grafts are blocked within 5 years. So at 40 years, this guy will be living off a lemur with blocked stents, CTOs in his native vessels, and potentially 2 blocked vein grafts. And where do you go from there?
Yeah, I think that's a very valuable comment, Vani.
anyway, the patient must be fully aware that Lima to LED is more than 95% patent at 10, 20, and 30 years.
Yeah, no,
I'm not saying
Marco,
the patient is surgical, but
I think you make a very valuable comment
fully
that
aware.
we should be considering all options. I think the value of understanding that we have a duty to do our interventional procedures as well as possible, and this is a reflection of a case which has been done suboptimally and results in failure. And you are now showing us how you're going to go about hopefully optimizing this with every intention that we maybe hold off future revascularization, but maybe there will be a requirement in the future. Show us how you did it.
Yeah. Basically, from now on, it was a straightforward procedure because we could do only one thing, no discussion about the strategy. As in last case, we can do only internal crush. And what we needed to do in this situation, first we performed sequential crush, and then when we performed kissing, we performed high pressure kissing in order to push that layers of stent and intima aside, because we needed to really open the path to the side branch. And this was the result after this sequential and kissing balloon inflation with NC balloons. We had satisfactory results, so we needed to optimize the situation for long-term prognosis. So we performed 2 drug-eluting balloons inflations sequentially, and then, although it should not be done, we did a gentle kiss because now we have a stent neocarina in place, so we needed to put it in the middle. Also, we optimized the most proximal part of the previously implanted stent because there was small malposition, and this was the end result of that second procedure. Should we look at the OCTs or yeah? This was the pullback from the diagonal branch. We can see the disease in diagonal still present distally, and restenosis is abundant in those 2 stents. But we can see now the stent is really wider, probably 3 millimeters in diameter after inflating the larger balloons. And we come to the polygon, and it's a really long pullback, sorry. And this was the polygon. You can see now why really well opened situation. Also the pullback from LED, it's quite similar one, but this is the images that we need to see. It's the polygon of confluence, and we can see on the bottom pictures where we can spot the free layers of the stent. The stent is not crushed with something like cheeseburger and on 3 floors, and everything is pushed aside enough to have the wide opening towards the side branch. And this was the final 3D pullback towards the LED. Diagonal is on the 11 o'clock. You can see wide opening of the side branch. Thank you.
Drop the mic. So, I mean, I think you raise at this point another important consideration. I mean, Marco, you were animated about sticking to guidelines. The guidelines would now suggest that this guy should have had drug-eluting stents for the treatment of his restenosis. For me, that shows that the guidelines are an ass. Yeah. Because quite frankly, putting more layers of metal into this patient is ludicrous. So you should be commended on the fact that you went against guidelines for the purpose of managing this very aggressive restenosis with appropriate preparation, image-guided, drug-coated balloon treatment.
I fully agree. We had discussion before that step, so it was really consensus. The Professor Stankovic was also in the room, so we were lucky to have opinion makers in the room.
So I want to ask you something about this patient is not diabetic. He's not diabetic.
That's the only missing.
He has familial hyperlipidemia or something, because these coronary arteries are too small for 35 years old. It's very small coronaries. And the aggressive disease, I mean, yes, part of the 50 years lifespan that he might have for the future, you will probably need an injectable PCSK9, a high dose, statins, combination, whatsoever. because all of these factors will be interfering with the future, because the coronaries are very small. His body build is small or something?
No, he's regular size male. So
average size. The coronaries are so small for an average size 35.
Well, we have just one or two further questions. Please vote. We have 16 on the poll so far, but it would be nice if everyone in the room could provide their opinion, if they haven't already, vocally. Any other comments? I mean, it's been Francesco. It has been a fantastic group of cases which has generated fantastic debate.
I think that this case really highlights how important can be dedication to all the steps into complex double stenting procedures. At the end, I feel that the area that was achieved at the polygon of confluence was very low, and this make a carina something that is very close to the main vessel proximal. In the case you are able to create a big polygonal confluence with, a big sequential kissing, most of the time this can be tolerated. I think that, and other point is the fact that we are willing to systematically perform eventually the imaging in the case of restenosis. But when we have a double stenting procedure, I think that it is the typical condition where a final imaging can allow to treat during the first procedure something that is easier to be fixed as compared to at the time of occurrence of restenosis, because you have the same amount of metallic parts plus the restenotic tissue. So overall, it becomes much more complex.
Thanks, Francesco. I mean, your comment around the index procedure, I mean, Zlatko stated that they were happy with the angiographic result. And that comes back to actually that first comment I made before we started, which is the eyes can't see what the mind doesn't know. To consider that that was an appropriate angiographic result demonstrates a failure of understanding of the bifurcation. And even if you don't have access to imaging, then doing a stent boost would have demonstrated the fact that that side branch diagonal stent was protruding into the main vessel. So it's not imaging. I think it is just taking care and being sequential in your approach to trying to achieve a durable result. But I hope that people have had a chance to vote. We have 37 votes. Should we try and get it to 40 votes and then we close?
Tom, just in addition to your last comment, do you think you can ever actually get a good tap? Isn't it just a dreadful procedure?
Well, there are people in the room that might want to defend TAP. Oh, yeah. Well, I think it would come down to the angle of the bifurcation. Such a shallow bifurcation, then the concern would be around how much near carina you're likely to generate. So, in such a shallow angle, I would agree with you that it doesn't seem like the right choice.
Even in less of a shallow angle, then you can end up with a situation that we did in the previous case, that when you're going back in, because there's restenosis at the ostium and the side branch, you don't know where your wire's going. And luckily, in this case, the wire went where you wanted it to go. But that's the problem with TAP, isn't it? When you go back in, it's always going to be an issue. So why do it? You know, if you really needed a side branch stent in the first place, you can do a crush at that point.
Or even a clot with the fact that stents will overexpand sufficiently. Gabor, your final words. We've hit 45 votes. I think we've done well.
Just to this question, my feeling about TAP, that this is the technique which requires the perfect angiographic projection. So whenever you cannot achieve this, you are not certain about this, then this is not the technique that you can do safely. And this might be my feeling about these comments, that if you have a projection where you think that you cannot avoid overlap, then it's a matter of chance where the stent lands.
Thank you very much. So in the meantime, we got the final results from the vote. And the winner is Sinjini Biswas, for if you don't look it, you don't see it. and congratulations.